Hello. I hope you all started a good weekend. We welcome you to the public health talk from AIG Hospitals, Gachipoli by Department of Orthopedics. I'm Dr. Srinivas Thati, consultant orthopedic surgeon specialized in joint replacement surgeries and sports injuries. The aim of the talk today on total knee replacement, the myths and facts, is to educate the patients about the common issues related to knee replacement. I'll be using the best evidence available from the literature so that it's become a benchmark which will help in decision making for our patients on knee replacement surgery. So what is knee replacement? A total knee replacement, if you look at it, it is not exactly we are completely replacing the joint. The joint is resurfaced. We remove the damaged part of the joint and replace it with an artificial joint so that the damaged part is completely taken off and the soft tissues which are balancing the knee joint for proper functioning or remain. When this joint is, when do we go ahead with a joint replacement? Before going to a joint replacement surgery, we certainly start off with non-operative measures like taking painkillers, injections into the joint. There are several different injection therapies available which are at the moment temporary only. They are not permanent cure for the end-stage arthritis in the knee. The commonly used injections like steroids, the viscosupplements, now plasma, platelet-rich plasma, and also stem cells. There's still at a temporary measures than a permanent cure. The permanent cure of the problem in end-stage arthritis still remains a knee replacement. Patients can also try physiotherapy. Weight is a big issue. Weight reduction can also help in improving the pain. If all these measures fail, that's when we will consider a knee replacement. Even though you have gone through all these stages, we do see a lot of patients coming back to us asking, is this the right time to go ahead with a knee replacement? So what is the right time to have a knee replacement surgery? I have gone through a lot of research articles and with my own personal experience of over 20 years, all the studies show a common point to a common thing, the pain and function. So a recently published study from Czech cohort where they have followed up patients for 9 years, those who have osteoarthritis in the knee, and they have seen what is that which is tipping the patient to go ahead with the surgery. And majority of the cases, as the arthritis gradually develops over a period of time with the severity, the sudden deterioration can happen. This is the sudden deterioration in pain as well as function which makes the patient to make that very important decision. And for me, it is a shared decision between the treating surgeon and the patient. When the patient function is significantly deteriorated, or we have to look for these 5 signs when the patient needs a knee replacement. I said again, is the severe knee pain which is affecting the day-to-day activities and also sleep. The patient has reduced range of motion of the knee, that is the knee movement is limited and the knee gets stiff. That affects the walking ability to do the stairs comfortably, and when the joint starts aching, particularly during the night, it affects the sleep as well. Not only this, if there is a visible deformity of the knee which is getting gradually worse and cannot be corrected, that is also a sign that the patient needs a knee replacement. The longer the patient waits with a fixed deformity or a gradually worsening deformity, when you look at the outcomes are not that great. So it is better for the patient to consider surgery at this time. And as said before, failure of non-surgical treatment certainly makes a good claim for having a joint replacement. So in summary, I would say when the patient's pain has worsened and it is affecting the patient's activities of daily living and also sleep, that is the right time to have a knee replacement. Moving on to the next question, what is the correct age to get knee replaced? And this is one of the common questions we see we get for phase 2. When you look at the age groups which are affected with the knee osteoarthritis, certainly there is a reduction in the age. I mean, we are seeing patients with arthritis early nowadays. Even patients who are around 40, 45 years, we are seeing arthritis. Then the big question comes, is this the right age to have a knee replacement in a patient who has gone through all non-operative measures and still has severe pain affecting the function? When we look at a lot of joint registry data, I have picked up the Australian Joint Registry to see what is the common age group where we do joint replacement. When you look at this graph, the yellow line is the ages where the incidence of knee replacement is highest, which is between 65 to 74 years. So 40% of the patients who have knee replacement fall into this category. The second highest category is between 75 to 84. However, as you see the graph going towards 2018, the patients between 55 to 64, they have gone up in incidence or in the percentage. So yes, more younger patients are getting the knees replaced, and certainly we may see this a bit more in the coming future because of the increasing incidence of arthritis in the younger age. So what is the right age to get the knee replacement? Considering the improved techniques of knee replacement, and also when the patient needs a revision knee replacement, we do have fantastic implantation available now. So even early age is not a contraindication, particularly when the patient has severe pain which is affecting their function and also sleep. The next question is, once you decide on what to proceed with the knee replacement, whether you have a half knee replacement or a full knee replacement. To understand this, we have to go back to the normal anatomy of the knee. The knee has 3 compartments. On the inner side, we call medial compartment. On the outer side is the lateral compartment, and under the kneecap is the patellofemoral compartment. In majority of the patients, we see all the 3 compartments involved. That's where we say patient is better to have a total knee replacement, that we do see in elderly. When it comes to younger patients or in some patient age group, even in the elderly, one compartment is predominantly affected and the other compartments may be relatively normal. In these cases, it is worth considering a partial knee or a half knee replacement. We have to follow very strict criteria for deciding on a partial knee replacement, because when you look at the Oxford data, which is coming from where the Oxford partial knee replacement has been started, they have fantastic results. But when you extrapolate the same data to the joint registries like UK Joint Registry, Australian Joint Registry, Norwegian Joint Registry, the data is a little bit different. The survival of partial knee replacement as per the Oxford is above 95% at 15 years. That means 95% of the knees which were replaced partially were still functioning at 15 years after the surgery. That is fantastic, because when you look at compare with the total knee replacement, That's what we see. The 15-year survival is very similar. However, when you look at the other joint registries, it is not the same. What could be the reason? When you deeply study these outcome studies, the common reason is not sticking on to the criteria strictly when you are selecting the patient. So the patients who are non-obese, that means the body mass index is low, those who doesn't have contracture more than, for example, 5 degrees of flexion contracture of the knee or more than 10 degrees of varus and an intact ACL. These are the absolute indications for a partial knee, particularly medial compartment knee replacement. The relative indications are like age more than 60 years, low demand activity patients. Even in the elderly also we can do the knee replacement, partial knee replacement. And the patient should not have any anterior or lateral knee pain. That is very important in the outcome of a partial knee. So a surgeon who strictly follows these criteria, they can give a good outcome when they do a partial knee replacement, which is equivalent. In fact, the knee functions better with a partial knee compared to a total knee because we are retaining the very important anterior cruciate ligament and the normal mechanics of the knee also well maintained, and it is less invasive and the recovery is also very faster. These are the advantages of the partial knee. However, it's very important that the surgeon sticks on to the criteria to give an excellent outcome. The next question is, when I decided on a knee replacement, we see in majority of the patients having both the knees affected. Is it good to have both the knees replaced at a time or one after the other? When we look at the research data, there is a lot of data which shows the complications rate in simultaneous, that means both the knee replaced at the same time, is higher. When you do a sequential knee replacement, that means one giving a gap of say 3 months and doing the other knee at a different time, the risk is less. They are safer, the risk of blood loss is less, so we don't have to transfuse blood, and the shorter recovery time. However, the only issue is the second admission, so the patient need to stay, and the rehab time. That is what is against the sequential knee replacement. When you consider the risks such as high risk of mortality and the morbidity, blood transfusion risk, and the longer recovery, and imagine the pain the patient has to go through having both the knees at a time, it is difficult it is not that difficult to make that decision whether you want to get a single knee done or both the knees done at a time. When I looked at some of the studies, among them I picked up this study from the Danish registry. It clearly shows the hospital complication rate. I mean, when the patient is inpatient within the hospital, the complication rate is around 15.5% in simultaneous knee replacement, whereas it is 7.3% in staged procedures. The risk of clots in the leg or the lung, if they form in the lung, is life-threatening, is also high in simultaneous. And when you look at the reoperated rates in the early on period, certainly their risk is around 3.4% in simultaneous, whereas 0.4% in staged. Again, the 30-day readmission rate is around 8.6% in simultaneous and 5.6% in staged. So the conclusion in majority of these papers, when you look at the conclusion, they say you have to safely identify the correct patient. I completely agree with that. You have to identify the patient who can be safely done, those who doesn't have too many comorbidities, those who are not on higher side of body mass index, those who maintain good activity, and the patients whose pain threshold is also a bit low compared to patients who are having higher pain threshold. So here also it is the very important factor, patient selection, which gives you the best outcome. I'm not against bilateral simultaneous knee replacement. I myself have done few of them, but my criteria are very clear when it comes to who I do a simultaneous total knee replacement. When you look at the other study, which shows perioperative outcomes again in both unilateral and bilateral knees, they clearly say those carried increased risk of perioperative mortality and morbidity when you compare with the unilateral cases. Even those which are staggered bilateral knee replacements. That means during the same admission, you are operating on two knees. You do one knee on one day and you operate on another day on another day. So you give a bit of a gap between the two knee replacements. Even in them, the mortality has no benefit and may even expose patients to increased morbidity. So there's a clear evidence from the research that you need to be very careful in doing simultaneous knee replacements. Once you decided on which side or uni or bilateral, then the next question comes is, what is the best implant? This is a very common question asked, and there are a lot of implants available in the market. But when it comes to the material, there are three important materials used in implants: the cobalt chrome, oxynium and niobium. When you look at all the joint registry data, the cobalt chrome is the mostly used in knee replacement. Next to that is the oxynium, and then niobium has been recently used. There's not much research evidence on niobium at the moment. So the cobalt chrome is just like steel looking when you look at it. The results of the cobalt chrome are better when you consider the survival rate. That means how long the joint replacement is going to survive. The 15 years survival rate is better in cobalt chrome compared to the oxynium. A simple example, one of the company has the same design of the knee implant, but these two different materials. When you look at the survival rate, the cobalt chrome survives better, and the revision rate was double in oxynium group. Oxynium is marketed as to be used in younger patient groups. However, when you look at the recent studies, even in the younger patient groups, the oxynium is not giving any additional benefit. Certainly the cost is more for the oxynium, but the survival benefit is not much. So I picked up a level 1 study published in 2018, which was given by award as well, Mark Coventry Award, which is a prestigious award in the orthopedic research. If you see the conclusion, given the absence of demonstrated superiority of either the cobalt chrome implant or the oxynium zirconium implant, we recommend that surgeons and healthcare systems can reasonably choose the less expensive device for routine use, unless there is some compelling reason. That compelling reason is when the patient is known to have metal sensitivity to cobalt chrome or the nickel, which is a part of the composition of the cobalt chrome implants. For me, this is the only indication for using oxynium. Unfortunately, there is not much data on the niobium implants in the literature, and I myself doesn't use because I go by research evidence. Once we decided on the implants, the next question is, what are the techniques which are used in knee replacement surgery? The common techniques are either you do a manual technique where the surgeon makes the cuts on the bone by identifying the landmarks, by eyeballing the landmarks. The aim of majority of the knee replacements is to align the knee in a single line. The center of the hip joint, the center of the knee and center of the ankle, they fall into a single line. This we call as a mechanical alignment. There's another one called kinematic alignment. I don't want to confuse my patients with these two, but majority of them are done for mechanical alignment. If the mechanical alignment is not restored, there's very good research which shows that the survival time of the implant is reduced. So if I'm more than 3 degrees out of this mechanical alignment, the risk of failure is high. The good studies should show that when we do on manual technique, my chance of being out of this alignment is around 30% or 35% nearly. Whereas when I use a computer, that drops down between 5 to 8%. That's where the computer navigation gives me an edge in not just eyeballing the landmarks while doing the bone cuts. It will guide me in making those cuts, in getting the alignment right. That's one reason why I definitely use computer navigation. There's a good research showing that when computer navigation is used, particularly in the younger patients, the survival of the implant is increased. The next method is the patient-specific knee replacements. Unfortunately, we are not doing much of patient-specific knee replacement because of the cost involved, the additional burden on the patients or the healthcare system. It does make a difference in improving the alignment and also cuts the inventory significantly and also improves the theater efficiency. Even though all this said and done, when you look at the outcomes, there's not a huge difference when you do a navigation or a patient-specific. The final one is the robotic, which is a newer technique. There are few robotic machines available in the market, but there is no adequate data to say that the robotic makes a difference in the outcome of the patient. Particularly that the outcome I'm talking about is the long-term survival. When you look at the robotics done, say 10-15 years back, and when you compare those with the current robotics, there's not a huge difference. And there's a recent meta-analysis published which shows no additional benefit. It can be a good marketing tool though. So what impacts outcome of knee replacement? This is very important for a patient who is considering to have a knee replacement. The main aim of doing a knee replacement is to relieve pain, to improve the function of the knee so that you can perform all your day-to-day activities without any difficulty, and also do some recreational activities to improve the quality of life. Along with that, the survival is very important to consider when you are thinking about a knee replacement. The three important factors which make a difference in the outcome: the patient factors, surgeon factors, as well as the implant factors. Patient factors, we have to look at what are the comorbidities a patient has, how they are going to impact. Particularly patients who are on the high body mass index side, they tend to have poorer outcomes and early failures. Patients who are at high risk of infections, particularly those who have severe rheumatoid arthritis, uncontrolled diabetes. Here you have to listen to this very carefully. I'm saying uncontrolled diabetes, not diabetes in general. Those who have uncontrolled diabetes, their risk of having an infection is high. The other ones are those who have immune suppression, who are on immune suppression therapy. These are the common patient groups who can have a lower outcome or a poorer outcome compared to somebody who is healthy with not many comorbidities. Coming to the surgeon factors, yes, it is very important how experienced the surgeon is when he is doing the knee replacement. What is the surgeon's understanding about a knee replacement? How the surgeon is selecting the patient? What is the volume of the surgeon? Is a high volume surgeon, low volume surgeon, or is a carefully balanced surgeon? And technically, what the surgeon uses, what implants is the surgeon choosing? All these factor in, and the training of the surgeon is also very important. Unfortunately, in our country, there is a lot of variability in training, and with the fellowships available, there is some standardization of training coming into place, but still we are not to the level where the Westerners are. So surgeon factors makes a key role in the outcome of a knee replacement. The surgeon's aim would be to align the knee appropriately within that mechanical axis and implant the knee in such a way that the fixation is satisfactory, and also give a balanced knee. That means the soft tissue balance is maintained very well. This is where I say the robotics is not doing everything. It is a surgeon who is doing it. The robotic is only cutting the bone, but making that call of where to cut the bone, how to balance the soft tissues, how well the cement is used in fixing the implants. These are all under the surgeon's remit. If the surgeon is not able to do that correctly, yes, the risk of early failures are high. Unfortunately, we don't have the data, adequate data in India yet. Hopefully, we'll be able to gain some data with the efforts of the committees. Implant factors is also very important. I've already touched on the materials. The implant designing is very important, and you have to look at the joint registry data to see which implant is working very well, which implant is failing early. When we consider all this evidence, then you can safely give a knee replacement which gives you fantastic outcome. Talking about the outcome studies is beyond this talk. I will definitely do a talk on this in the near future. And also I'll talk about the surgical techniques as well. Keep a watch. So how long does a knee replacement survive? This is also another common question which is being asked. As I said, already touched on many of the points. So the implant survival depends upon patient, surgeon, and implant factors. Not only that, when you look at the patient factors, age and BMI have a significant effect. Certainly younger age group patients are found to have lesser survival compared to those who are elderly because of the activities or the demands which are put on the implants. High BMI certainly has poorer outcomes or poorer survival. Surgical techniques, particularly accuracy of placement of the implant, and also the cementing technique in fixation makes a big difference. Implant design and the fixation. When I'm talking about the fixation, there are two types of fixations available: cementless and with cement, or a hybrid one. And all the studies shows that the cementless fixations are failing early, and that's why there's a big shift towards cementing. And the cementing technique is very important, which is completely surgeon dependent, and what type of cement we are using to fix the implant into the joint. This is very important for implant survival. When we look at survival of the knee replacement at 15 years, 95% of the implants will survive when chosen optimally. At 25 years, 80% of the implants are surviving. So we can safely say that knee replacement has fantastic survival when it is done correctly, perfectly. To take home, I would like to say total knee replacement is a safe procedure and a very common procedure. There's no need to fear when a orthopedic surgeon says you need a knee replacement, because it improves the quality of life significantly. It improves the patient's functioning very well, and the pain is significantly improved, and you don't have to depend on the painkillers for a long period. The timing of the surgery depends on mainly the pain and how this pain is affecting the function of the patient. This is when you have to decide when to have any replacement. Age is not a criteria, it is only a relative contraindication. I won't even say a contraindication. Age is only a number, but pain and how the knee arthritis is affecting the function is the important parameter to consider any replacement. Partial knee replacement has limitations, but when chosen the right patient, the patient can get a fantastic outcome with good longevity or survival of the implant. Stage TKR is safer with less complication, That doesn't mean that I'm ruling out a simultaneous knee replacement. Here again, the patient selection is very important. When we select the appropriate patient, simultaneous knee replacement has good outcome, as good as a staged one. Sometimes because it is going to save money, it's cost effective, as well as length of stay within the hospital and rehab will be limited. When it comes to implants, still the standard implants are cobalt chrome implants. I'm not a big fan of oxenium or niobium at the moment because there is not enough evidence in the literature or the research. I'm talking about a properly done research, not the corporate research. So the cobalt chrome implants are still the gold standard. I would still use them without any hesitation. Outcome of the knee replacement depends upon these three important factors which you have to always remember: the patient factors, surgeon factors, and implant factors. So please choose your surgeon carefully, and also the implant which is going to be fixed into your knee carefully. At AIG hospital, we do a standard knee replacements with computer navigation at a cost-effective level. Please reach us if you have more questions on my email. Thank you for your participation. I would like to answer some questions which have come through. Right. The first question is by Ms. Ramya Sweti. So my age is 26 and having a meniscus tear, 7 mm, is surgery must, sir? Okay, I know it is out of the topic, but as a sports surgeon, I can answer this question. We have to look at how this, where this tear is located. Meniscus is a very important part of the knee, which is a shock absorber in the knee joint, which also helps in circulation of synovial fluid and also nourishment of the joint lining, which is what damaged in knee arthritis. Meniscal tears in young patient, if they are in the zone where the blood supply is cut off to the meniscus, they definitely need repair. If the tear is a degenerative tear, which is on the edge, we call this as a white zone where there is no blood supply, the repair is futile. That need to be removed if it is causing symptoms. Majority of the times the symptoms with meniscal tear are either pain or instability. If it is causing instability, certainly that is the indication for surgery. So I need to assess you before I can say whether you need a surgery or not. But having a tear in the meniscus itself does not mean that you need to have a surgery. But how it is affecting you, how it is going to impact your long-term knee function need to be considered before thinking about surgery. I hope that answers your question. The next question is from Mr. Hari Krishna. What is the percentage pain after knee replacement? That's a fantastic question. Thanks for asking that. The pain improvement depends upon what stage of arthritis you're having the knee replacement done, how severe your knee symptoms are, what is the deformity, how severe the deformity is, how much of knee movement do you have, which part of the joint is more affected. All these will determine how much the pain is relieved after knee replacement. In majority of the patients, 90 to 95% of the pain is improved. And in patients who have severe deformity of the knee with a flexed deformity, where we need to do a lot of soft tissue releases to correct the soft tissue balance, those patients may have a bit less improvement in pain. I would say 80% of the pain will be improved. And patients who have patellofemoral joint involvement predominantly. That means under the kneecap if you have a lot of arthritis, these patients also have lower pain relief compared to somebody who has a global arthritis. So patients with severe deformities, patients who have more patellofemoral arthritis, patients whose comorbidities are more, and particularly like high BMI, diabetic patients, their pain relief may be a little bit lesser compared to a general patient group. So it is very important to understand or give an idea on how much pain relief you can get after a knee replacement. There's a way of doing this. We can do some studies, the outcome scores we can do. We can use a Oxford score, which is specific to the knee joint. We can use a Q score, which is a knee specific measures as well. And we can use a OMAC score, which will give the entire general well-being of a person. So when you consider the general well-being, how we are scoring on that, and then you consider the knee specific scoring, then we can give a certain amount of idea how much of pain can be improved. If the Oxford score is very poor, and when we do a knee replacement, when in 6 months time, when we redo the score, we expect certain amount of improvement. Majority of the time, patients will improve by 15 to 16 points. If they have improved beyond that, that is the best outcome when it comes to improved pain and function. So, can we give a percentage? Yes, 90% of the pain will go away. 90 to 95% of the pain will go away when it is done in optimal time, when there are no fixed deformities, when there is no severe wear and tear under the patellofemoral joint, when the knee is not too stiff. But if the patient has severe deformities which are fixed, stiff knee, severe involvement of the patellofemoral joint, and when they score low on the general well-being, it might be around 80%. I hope that answers your question. The next question is from Mr. Narendra. During recovery, what are the precautions we need to take at home? Thank you very much for asking that question, Mr. Narendra. Post knee replacement, therapy takes a very important role. I always tell my patients the importance not only after surgery, even before the surgery. I send my patients to have prehab, that is therapy before having surgery, so that the muscles are started to work along and the knee movement is maintained and the overall trunk control is improved. Post surgery, the important things to do is keep moving. I would ask my patient to be more mobile than not moving much. You have to try and reduce the swelling. The swelling is a main cause for pain apart from the surgery. As the swelling increases in the knee or the entire leg, the pain gets worse. The stiffness is also going to get worse. So you have to avoid these. To avoid this, for the swelling reduction, keep the leg up elevated. Keep applying ice regularly around the knee. I would say at least for every 10-15 minutes for every 2 to 3 hours. Keep doing the exercise. Keep yourself mobile as much as you can. Keep the dressings dry. This is very important. The dressing which is on the knee should not be made wet because that can increase the risk of infection. That is very important. And the other precaution, important precaution is when you are mobile, make sure that you are walking on safe floor. Use your either a walker frame or the crutches. I prefer crutches, elbow crutches, 2 of them, so that gives better gait, which is more natural. Walker is also accepted. However, I tend to use the walker for elderly. But whenever you're walking post knee replacement immediately after surgery, better you use the supports and keep doing your exercises. When it comes to diet, yes, maintain good diet. I don't say not to take this and that. There are different parameters you have to look at when it comes to diet. If your patient has diabetes, you have to make sure that you're maintaining your blood sugars well and take diet accordingly. Don't overindulge. When patients have any renal problems, make sure that you're not taking any diet where the potassium levels are high. So please talk to the dietitian about what is the optimal diet. And sleeping posture is the common question asked. Can we sleep on the side? I don't see any problem when the patient wants to sleep on the side, either on the operated side or on the other side, but keep a pillow under the leg to elevate so that the swelling comes down. Don't forget the other joints, keep moving the other joints so that you can maintain the flexibility of the other joint and prevent stiffness. Stiffness itself is a problem and it can reduce the benefit of the knee replacement, so prevent stiffness. So these are the simple precautions which you can take after a knee replacement. Next question is, what is the right time to undergo a knee replacement by Mrs. Surya? Thanks for the question. One of my slide does answer, and again I would like to repeat, it is not the age, it is mainly the pain and how the pain is affecting the patient function and ability to do the day-to-day activities, and also the sleep, which form the main criteria in deciding the right timing on knee replacement. Certainly we have to look at radiographically what are the changes, and we have to make sure the pain is coming from the arthritic knee rather than from any other source. So yes, the important criteria on timing the surgery is how bad is the pain, how it is affecting the function of the patient. And another question from Mr. Surendra Reddy: what activities I should avoid after surgery? So you have to think about immediately after surgery and at a later stage. The immediately after surgery, certainly patients will not be able to sit on the floor. I don't limit my patients on activities they can do immediately after the surgery. The only thing I would say to avoid is sudden twisting movements, walking unaided, at least for first 4 weeks. The first 4 weeks, it is always better to walk using the supports, either the frame or the crutches, to avoid any excess load or twisting movements onto the knee, because the tissues are still in the healing phase. The common other question patients ask us is, can I go up and down the stairs? No problem. The patients can go up and down the stairs without any issue. Once you have completely recovered, when can I start driving? That is another common question. Majority of the times, the reaction time, the break time, there's a very good study done in the Western literature. When can I start driving? It's usually after 4 weeks. I wouldn't let my patients drive before 4 weeks, because the reaction time for braking comes to pre-surgical level around 4 weeks after surgery. And following that, can I walk long distances? Absolutely, you can walk long distances. You can walk on the treadmill. You can do cycling, which is more a closed chain activity. You can do static bike and road bike as well after, say, 6 weeks after surgery, once you have restored all your movements in the knee. The cross trainer is absolutely fine. Can I lift weights? Not too heavy. I wouldn't expect post knee replacement patient will be able to do any deadlifts, but small weights within the aerobic level of activity are absolutely fine. So the only limitation is not able to sit on the floor for a long period initially, but once the knee gets the movement full movement, for a short period the patient may be able to sit even on the floor, but I would try to avoid doing that for a longer period. I hope that answers your question. And I think we have one more question. I think we are getting a few more questions, but because of the time constraint, I may have to stop here. I hope this has given you some perspective of what are the facts in getting done a knee replacement. I hope you enjoyed the talk. Please reach us on our email, or you can get through our appointments if you need any further queries answered. Look forward meeting you again in our next talks on similar topics. Thank you very much. Have a good weekend. Bye bye.